Telemedicine Society of India, and our Dr. Natarajan will be joining shortly. So I request Dr. Kim to give the talk on technology in retina. So teleophthalmology is the new science and new branch of ophthalmology. It's upcoming branch. Many of us, because as you know, 80% of India is in the rural India and 20% only urban. Many of us are doing some sort of teleophthalmology, but still we are far away from delivering the modern eye care to the poorest man in the rural area. There are a lot of areas in our country where there is no roads, no transport, and no doctors. It's very much inaccessible. So under these circumstances, probably teleophthalmology will be the answer for delivering the modern eye care, the advanced eye care at the rural area through digital technology. India is going in the digital way, and we are sure in the next few decades, everything will be digitalized. So why not healthcare and why not eye care? For that reason, we have formed the society, the Teleophthalmology Society of India, to integrate all the teleophthalmology specialists all over the country. No doubt, there are very good centers as Arvind Eye Care System, Shankar Nethralaya, LVP Eye Institute. They are the leading institution in our country. They are doing this teleophthalmology since a long time. And they are our members to guide us, to prepare a guideline so that all of us can do teleophthalmology and deliver the eye care, modern eye care to the common man in our rural India. So these few introductory talk, I request our first speaker, Dr. R. Kim, to speak on technology in the retina. Thank you.
Good morning, and thank you, sir, for the introduction and the importance of telemedicine, especially in a country like India. Well, I'm not sticking on this. My topic is technology in retinal disease management. Actually, I had only AI in my mind when I said this, but I didn't realize there will be multiple AI talks, and it could be a repetition of the other talks too. So I do not have any financial disclosures. Today, as a retina person, we all understand that technology plays a major role in the diagnosis and management of retinal diseases in compared to all other specialties in eye care. I've very often seen that when I see a patient who has come with the fundus photo taken, OCT taken, and you hardly have anything to see, because today all the ultra-wide field is giving you a much better view of the fundus, and the OCT is there for you to see. So even if you're going to look at the macular edema, you're going to see a two-dimensional picture, but not the whole structure which the OCT would give. So your decision on the management is made just based on looking at these technology devices' outcomes. As I said, the retina is the most difficult area to visualize in the eye, for which the indirect ophthalmoscopy was born, and then up came the fundus camera, and then the series of imaging devices. Today we have any number of those, starting from a simple non-mydriatic fundus cameras to the ultra-wide field imaging devices like optos. In management, we have lasers, multitude of lasers, and we have different lasers that have come in the market for us to use. Imaging, as I mentioned, earlier the fundus cameras were expensive, prohibitive to buy, but today you get them as cheap as 2 lakhs to anywhere above that. So it is affordable for every ophthalmologist to buy these fundus cameras. And with all the increase in the prevalence of diabetes and diabetic retinopathy, the need for using these fundus cameras becomes all the more important. Of course, ultra-wide field cameras are still prohibitive to buy because of the cost that is there. But again, it's a matter of time when they would become very easy for any ophthalmologist, general ophthalmologist, to even afford this. OCT and Octa has made a huge change how OCT made a change in the way we see retina. I think the OCTA also is making the change in how we are perceiving or looking at the retinal diseases. Surgery, the most expensive and complicated microscopes are being used by the retinal surgeons for the need to look into the back of the eye with the 3Ds and the ingenuity and the RTOs, which helps you to just not look through the microscope, just look at a TV screen and operate, have made your life easier, especially for the back problem that many of the retinal surgeons are known for. So today we have microscopes integrated with OCT, so as you operate, you know which layer of the retinal membrane that you're peeling, and this helps in many ways in precision in the way, because you're today operating on patients who have 6'9", 6'6" vision in the retinal area because of the epiretinal membrane or many other pathologies that are there. So today those are all possible because of the technology, the advanced instruments that we have in hand in being able to touch these. One of the important thing that has come in the recent times is the introduction of artificial intelligence, the most noteworthy development in ophthalmology over the last decade. It has made it is making a lot of changes in the way we are going to manage the retinal diseases. It started with the diabetic retinopathy screening. Sir mentioned about those remote areas where patients do not have access to care, are these places where we can do the diabetic retinopathy screening, what we call as tele-screening, using simple fundus cameras. We have been doing this for the last 20 years in different diabetic clinics, putting the fundus cameras, asking that of technicians in those clinics to use these fundus cameras, just take pictures and send it to us, where our retina specialists would read these images, grade and send a report back in an hour or 2 hours time, so that only those patients who have any retinopathy are referred to the ophthalmologist, which is like 20% of they are at any given time, and 80% they can be asked to visit after 1 year. But there are challenges in this whole process because, one, the availability of the retina specialist time for grading these images is a monotonous work. They are better used in diagnosing and retinal diseases or managing the retinal diseases than sitting in front of the system and grading these images. But more importantly, there's a lot of inconsistency in the way different people grade these images. So how do we address that? I think AI algorithm came in at the right time. And myself and Dr. Rajiv Raman here, both of us had worked with the Google team to develop an algorithm using multiple images. These algorithms were trained to diagnose and grade the diabetic retinopathy at different stages. And today we are able to do that in real time. And both of us have done multiple validation studies to see if this AI algorithms are working fine. And they found that it is better or even comparable to the retina specialists, leave alone the general ophthalmologist or the grader. It is doing a much better job in identifying even the finest, earliest mild diabetic retinopathy, which very often many of us may miss to see. So things I can do but are not a good use of time is what AI can replace us with easily and works consistently. But there's also other things that AI can do, that is find new signals which human eyes cannot see. As I mentioned, today we are using this for the last 3-4 years in real time after these algorithms got approved. And we have screened till date about close to 700,000 eyes for diabetic retinopathy. So what we have done in this whole process is just replace the grader with a AI tool and with a turnaround time of 1 minute. And this is available 24/7 to the diabetologist, so they don't need to depend on us for grading or screening this, which is a big value addition for the diabetic patients because they are there for the diabetic screening. And at the same time, they're getting their eyes screened or the retinopathy screened, which is only those who really need to go to the ophthalmologist even if their vision is good. But very often patients do not come because they say their vision is good and sugar is under good control, they think they can get away with it. But little do they realize, once they see their images that they have hemorrhages in the eye, then they are a little bit convinced that they need to do something about it. So I just wanted to look at this data that we had. I was looking at the data before we introduced AI in our screening program. We screened about 200,000 patients in 1 year, that is 2018, and our DR diagnosis was around 1,090 patients. Whereas in 2022, when it was fully integrated with the AI, the number increased tremendously. Whether we were missing out or we don't know, we are trying to understand what are the reasons that this number went up 8 times to identify those diabetic retinopathies, which we didn't do while screening earlier on. So there is definitely an AI which is doing a lot of progressive activity that it's showing that we can do much better, but still there's a long way to go. Detecting diabetic macular edema with just using fundus photos, looking at the fundus photos, can you say whether the patient has got macular edema without doing OCT? Looks like it is possible with the AI, but this is work in progress. Again, Rajiv's team has done a tremendous work in trying to predict whether these patients can, those who develop diabetic retinopathy, those who, if you want to inject anti-VEGFs, whether those patients would respond to treatment. How good it will be to know that if you're going to give the injection to this patient and you knew ahead of time, there is the fair chance that this patient will respond to the anti-VEGF, then you're justified in going ahead and giving the treatment. But today we are blindly doing it, hoping that it would work in most of the patients. This is another interesting factor that what AI can do, predicting the risk of developing diabetic retinopathy. A patient who does not have any retinopathy, but a diabetic patient who has no retinopathy, you take their fundus photo and subject this to the algorithm, and the algorithm is able to predict what are the chances that this patient is likely to develop diabetic retinopathy in the next 5 years. So if you can identify those high-risk patients, then you can follow them more closely, ensure that they have a good diabetic control, rather than the other patients who are less likely to develop diabetic retinopathy. Again, this is a work in progress and needs to be evaluated. So I'm sorry I overshot the time. So AI can play a major role. We know that it can predict the sex, gender of the patient, cardiovascular risk factors of the patient. What we are now working on is using just the simple fundus, your mobile phone, taking a photo of the eye. It is able to predict multiple systemic biomarkers. This was published last year, especially kidney function. Take an eye photo and you're finding the function of the kidney, EGFR, hemoglobin, and all these levels can come just out of your fundus photos. Again, this is a work in progress. This is another, the software that I saw based out of Canada. They say the tagline is take a selfie and know you're healthy. Just take a picture of your face, and I believe it is able to predict all these parameters it is able to give. And this is approved and waiting for FDA approval now, but it's approved in many other countries. So they're far ahead in using AI in these spaces. So no need for blood tests or many of those investigations, looks like, at least as a screening tool. Home monitoring tools have come in using AI, and we are trying to see if we can develop AI tools that we can use in the rural areas that Dr. Subudhi was pointing out. Can we just use a non-skilled person to triage the patients in the villages to identify those high-risk patients using these AI tools and sending them into sending only those who have high risk to the ophthalmologist for further management. So there's a lot of work happening in AI. As they said, eye is the window to your body, which means the retina will certainly become the place for every specialist to look at and predict what the systemic disease is likely. So thank you, sir, for the opportunity.
So thank you, Kim sir, for the excellent talk. all of us know that Dr. Kim sir is one of the pioneers in the field of technology and AI and especially artificial intelligence, and has been acknowledged in different forums, including Mr. Sundar Pichai, and their work with the Google, what sir was mentioning. In 2016, the JAMA ophthalmology paper has been cited more than 2,500 or 3,000 times. Rajiv sir also agree. So all of us were very privileged, and especially me, because sir has mentored me starting from my fellowship with the ABCD of retina. He had taught me. So thank you very much, sir. Very excellent talk, sir. So for we invite Dr. Satansu Mathu sir for an introduction. After that, we'll have the talk of Dr. Rajiv Raman sir.
Sorry.
Yes, sir. Yes, sir. Yes, sir. Dr. Satansu Mathu.
Hello. Hello. Acha, ऐसे बोल देते. Sorry, I'm late. Actually, I was supposed to introduce, but Dr. Sabudhi has already introduced, I think. Why teleophthalmology is getting popularity in India? Because India deserves it most. It is a vast country, and to reach unreached remote areas is not possible by the experts. And teleophthalmology is the only concept that can give the specialized service to each corner of India, because 80% population of India is residing in the urban area, especially in the urban areas. Nobody wants to go to the remote areas. So this is the only way. The vision center concept has come really very nicely. Now I think I have also my vision center. So many of doctors are now employing the vision centers. And vision center only meant for this thing, teleophthalmology. They have to see, and they are not to treat the patient. They have to see and diagnose early stage and send it to the us. So definitely teleophthalmology is the future of India, future of world, and we have going in the right direction if we are starting first. And thanks to the Sivadhi who has started the Teleophthalmology Society, I request all of you to become the member of the Teleophthalmology Society. Thank you very much.
Thank you, sir, for the short but very precise point about the importance of TOSI. And with this, may I invite Dr. Rajiv Raman, sir, for his talk on AI for diabetic retinopathy screening. Dr. Rajiv Raman, sir.
Thanks, Dr. Subudhi. Thanks, Chitranjan, organizing such a nice session. And I think my work has been made very easy by Dr. Kim. He has already explained how AI can be used for diabetic retinopathy screening. I'll answer few of the questions because now we know that AI is working. And let's see that what do the screening guidelines tell us about DR screening and use of AI? How I select an algorithm if I have to purchase one? How we address the problems of non-gradable images? Will the same algorithm work for even if I have a wide field photograph? Is the performance of algorithm dependent on a camera? Can we have some other strategy like a risk factor based screening? What are the current evidences? And lastly, just I'll touch something on generative AI and diabetic retinopathy. So let's answer these questions in next 8 to 10 minutes. So the first one, what the guidelines say. So in 2020 was first time American Diabetic Association included AI for DR screening as one of the part for standard of care for diabetes. And they went ahead saying that you can use it as an alternative to a traditional screening approach. And they also went ahead saying when not to use AI. They said that if a patient already has known retinopathy, if he is already undergoing some form of treatment, or if he has visual impairment, because these are the indication where ophthalmologists should see. It's not where AI will work at all. So that's something you don't need to use AI. All India Association and Vitreoretinal Society of India came out with a consensus statement, and in that too we have included AI for DR screening. However, because we don't have a legal framework, the use is, we said that anything which is graded as referable should be again seen by those images should be graded by ophthalmologist, and at least 10% of even normal should be seen by ophthalmologist. So that's the guideline which All India Association has given. And very recently, last month, actually we have hit the nail, because whatever we say, the screening has to be done by the physician because they are the first people who see diabetic. And now we have made a guideline with RSSDI. So VRSI and RSSDI guidelines for diabetic retinopathy screening has come, and it tells all these questions that how to select a AI algorithm, how you can use it, and what are the government reimbursements if you do a screening for physician. Now let's see how to select an algorithm for the use. So whenever you are looking, you get somebody says that I have an AI algorithm, it works very well. Try to see that what was his training set, on what basis he has created this algorithm, how was the ground truth ascertained. Because majority of time, as diabetic retinopathy, we have seen even retina specialists can make mistakes. So whether it was 1 grader, 2 grader, like Google paper which we had 54 board certified ophthalmologists who graded the images. Whether the algorithm was trained using images which were captured through a mydriatic camera or a non-mydriatic camera. Because so ultimately it depends how you intend to use it. If you want to use it in a non-mydriatic mode and you use an algorithm which has been developed using a mydriatic image, on that performance they will say it works 98% well, 99% well, but when you really use it, the performance would be low. And whether it was trained using a single field versus multiple field. Like if you look the IDX, which is the first FDA approved, the algorithm was not made on single field, but on 2 fields. And what we do in our clinical practice is single field. So there is no sense, even if IDX says that it is 99% accurate, you will not get that accuracy when you try to use it. So you select the algorithm depending on the circumstances of your intended screening, how you want to use it in your clinical practice. This was an interesting study which we did. We used a AI algorithm which was developed from Selena, that is Seri. It is inbuilt into a Zeiss camera, and though the Selena was developed using mydriatic images, we used it on a non-mydriatic image and saw whether the performance is good or bad. I'll not go into detail, but the sensitivity is pretty good, specificity reduces. However, nothing, in comparison with nothing, this definitely works, but not as good as an algorithm which is developed using a non-mydriatic image. How to address the problem of non-gradables, because this is the major chunk. Whenever you are using a non-mydriatic camera, about a third of the images would be non-gradable. And now there are AI algorithms which can detect whether an image is gradable or not. So this was a work which we had done in collaboration with a UK group, and we found that we can detect with a very high accuracy whether the image would be gradable or not. And if it is non-gradable, it can give a prompt to the photographer that you can retake the image so that we can get a better quality image. Will the same algorithm work if we use it in a ultra-wide field image? People have tried. So AIOC is a company who made initial with a single small photograph and used that algorithm for ultra-wide field imaging, and they were fairly successful. However, this was one of the work which we had done with Dr. Carol Chung, and we have developed the algorithm for wide field imaging, which is very fairly accurate to detect the lesions and classifying diabetic retinopathy. Is the performance of the algorithm dependent on camera? And this we could do because the Google AI was used extensively in Thailand, which had nearly 600 cameras and all different brands. So we saw that, is it comparable, all camera, is there any difference between them? And what we found that if the image is gradable, the performance of AI seems to be similar. If it is non-gradable image, definitely it is, but for a gradable image, a good algorithm will work across the cameras. Can we do something on risk factors? Because we cannot screen 101 million people with diabetes in our country. If we say that you need to take a dilated or you take a retinal image for everybody, next to impossible. So definitely we need alternative approach, and one of the alternative approaches that can we identify only a high risk group and do a retinal screening for them. And this was actually, we used all the available population based data. So this was from Arvind Eye Institute, from MV Diabetes, from Shankar Nethralaya, all population based studies used that data which had all the risk factors and created algorithms. So I'm not going in detail with the steps how we created it. We used something which people use in gaming called as Shapley methods, and even t-tests. We ranked these risk factors and came up with an algorithm that just without retinal image, if you feed in these risk factors, accuracy AUC of 0.8, we could say whether a person will have retinopathy or not. So probably a sequential, first a risk factor based screening, and if you are positive, take a retinal image is an answer for a country like India. Lastly, just touching that about generative AI. So today that is the buzzword, and AI is going in, more and more work on generative AI is happening. And this is a very recent work which we have published, work which was spearheaded by Dr. Tin Wong, and we were part of it, lucky to be part of this study, where they tried looking at can we use a deep learning system for predicting the time for progression. That becomes important. So this algorithm, you put the image and it will say that in next 4 years, whether a person will progress to a high risk of progression or a low risk of progression to a sight-threatening disease. It was tested across nearly 7 populations across the world, all of them showing a good accuracies, and that has included generative AI also into it, which can give a prompt. So not only the diagnosis, but it also gives what to be done. So it's a text report which comes that you need to, laser is needed, anti-VEGF is needed. Now you can just relax and come again after 3 months. And what we found in our Ascend Dreams data set, by using this algorithm, we routinely tell our patients that you come for a follow-up every year. And by dividing using this AI algorithm, high risk and low risk of progression, we could extend the follow-up to average 31 or 32 months. Now that's a big thing, because you don't ask them to come every year. They're coming 32, the overall load for diabetics to be screened reduces. And this also reduced the frequency of screening to about 62%, and the model had only 0.37% rate of delayed detection. Rest all it could pick up very well. So this is something which we will see in future. Our load, so though we have 101 million people of diabetes, we will have these strategies which can significantly reduce, so that we can do effective diabetic retinopathy screening. Thank you very much. Any questions? I'll be happy to answer.
Thank you, Dr. Rajiv Raman, sir, for the excellent talk. I have one small question, sir. That Thailand study with Dr. Pyson and all, you told that different cameras you use. All of them were handheld camera of different company, or
No,
tabletop
not
camera?
handheld. They were table. So
Tabletop
they were
camera.
Topcon. They were majority were tabletop.
And
Canon was the only handheld tag. Though they didn't had Remedio and others which we have in India. So Canon was the only handheld camera which was, but that also performance was reasonably well.
So there was no significant difference.
No difference. So that's what I told. If an image is gradable,
Yes, sir.
gradability changed across the cameras.
Yes.
So there are certain cameras which are, we know that tabletop cameras will have better, patient cooperation, your skill required is less, so more chances of getting a gradable image.
Yes.
But if it is a non-gradability may change between the cameras.
Yes, sir.
But if it is a gradable image, the AI performance is same.
Okay, sir. Thank you, sir. Any questions for Dr. Rajiv, sir? Okay.
Thank you.
Any comment from the panel? Any questions?
It was a really amazing talk, Dr. Rajiv, because in diabetes, the early detection and the treatment and monitoring the progress is the most important thing. It can really reduce the overload of diabetic screening once the AI has come up. So we have a great future. Thank you so much.
Thank you.
Thank you very much, sir. Thank you. Thank you, sir. So we'll move to the next talk of this session by Dr. Abhishek Sachdeva, sir. Teleophthalmology in ARMD. Dr. Abhishek.
He's from Jammu, mostly practices teleophthalmology in the hilly areas. He has a vast experience on teleophthalmology, and I would ask him to share some of these experiences with us.
So good morning, I am Dr. Abhishek from Jammu. So today I'll be talking on artificial intelligence in age-related macular degeneration. So age-related macular degeneration is one of the leading cause of vision loss in the elderly population, and the application of AI provides convenience for the diagnosis of AMD. ARMD is the third most common cause of blindness in the world and is the leading cause of blindness in higher income countries with aging population. Approximately 5% of blindness globally is due to ARMD, and it is estimated that globally 196 million people have ARMD in 2020, increasing to 288 million in 2040. The annual incidence of early and late ARMD is 1.59% and 0.19 respectively. And the European and Asia regions have a higher incidence of ARMD. So age-related macular degeneration is a disease that affects a person's central vision and can result in severe loss of central vision. Risk factors for ARMD include aging, being 50 and older, smoking, higher blood pressure, and eating a diet high in saturated fats. And global prevalence of ARMD and advanced ARMD in the population aged 45 to 85 old is 8.69%, and it has also been estimated that 15-year incidence was 22.7% for early AMD and 6.8% for advanced AMD in subjects aged more than 49 years old. So these are the AMD stages: the healthy eye, early AMD, intermediate AMD, atrophic AMD, which finally leads to blindness. So early dry AMD doesn't cause any symptoms. Intermediate dry AMD, some people still have no symptoms. Others have mild symptoms like mild blurriness in the central vision. And in the late AMD, wet or dry type, people notice that straight lines start to look wavy or crooked and a blurry area near the center of your vision. Colors may also seem less bright than before, and you may have more trouble seeing in low lighting. So how does AI work in ARMD? AI systems are autonomous and they can deliver clinical and diagnostic information on their own without the need for expert interpretation. They are developed by training a deep convolutional neural network, a type of AI on large data sets comprising thousands of patients with known outcomes. The network extracts features from these patients' retinal images, features such as size and type of drusen and pigment abnormalities. Imaging data are then combined with other patient data such as age, smoking status, genetic profile, and eye disease outcomes. With enough data, the network begins to detect patterns that can aid screening and prediction. So diagnosis of ARMD, as we know, is from fundoscopic examination, color fundus photography, fluorescent angiography, OCT, and assessment of foveal function, FCP, also termed microperimetry, can detect impairment through the central retina while correcting for fixation losses and Amsler grid. So this Eye Care Amsler Grid app, this application is designed for personal monitoring for vision loss for macular degeneration. With daily use of Eye Care Amsler Grid, small changes in visual function can be identified and electronically that may otherwise have gone unnoticed and caused long-standing damage. So AI for ARMD can detect referable ARMD such as intermediate to late ARMD and non-referable ARMD such as early or none. AI detects and classifies different stages of ARMD. AI algorithms have been applied to both fundus photographs, FFA, and OCT to detect age-related macular degeneration. Using retinal OCT images, AI systems can be trained to perform segmentation, classification, and prediction. Volumetric analysis of intraretinal fluid and drusen may also have been evaluated using deep learning methods. In segmentation, many AI systems were shown to display accuracy in segmenting different retinal layers on OCT, and this is important to quantify intraretinal fluid, subretinal fluid, and pigment epithelial detachment. So finally, treatment modalities: dietary supplements for high-risk dry or unilateral wet age-related macular degeneration, intravitreal antivascular endothelial growth factor drug or laser treatments for wet AMD, sportive measures. There is no way to reverse damage caused by dry AMD. Patients with extensive drusen, pigment changes, or geographic atrophy can reduce the risk of developing advanced AMD by 25% by taking daily supplements of the following: AI-based structural function correlation in patients reporting outcome measures. So it is seen during an anti-VEGF treatment, retinal imaging plays a pivotal role in disease management, with patients being regularly monitored by OCT. Beyond qualitative interpretation by the human eye, the automated analysis of these extensive amount of imaging data may be particularly useful for estimating of best corrected visual acuity. So for AI for prognosis and prediction, AI and intelligence machines learning based systems that not only screen for AMD but also predicts and evaluates separately one risk for developing late wet AMD and one risk for dry AMD, geographical atrophy. So age-related eye disease studies, major findings were taking AREDS or AREDS2 supplements reduces the risk for progression from intermediate to advanced AMD by 25%. AREDS and AREDS2 supplements do not prevent AMD onset. AI assists ophthalmologists in making accurate diagnosis and monitoring disease progression. In ARMD retinal OCT images, AI can be used to identify the difference between non-exudative and exudative ARMD. Using deep learning, AI have shown to achieve comparable diagnostic performance in...
Dr. Abhishek, can you go to the something about the most of
Yes, sir.
another 3 minutes left. You have to finish up as early as possible.
Yes, sir.
Yeah.
So in conclusion, AI was able to detect AMD in color fundus photographs and OCT. The application of AI-based automatic tools is beneficial for the diagnosis of AMD. Thank you.
But tell us how teleophthalmology will be helpful or useful in these circumstances.
Yes, sir. So, sir, with this, sir, with this AI algorithms with teleophthalmology, it's very easy to detect referable AMD such as intermediate or late AMD. And this AI is also helping us with classification different stages of ARMD. So this is for the classification. And this very useful tool of MSLA Grid app is very useful for personal monitoring of vision loss for macular degeneration.
I just have one question because we in teleophthalmology, the fundoscopy is feasible, but these algorithms, they include OCT. So how would that help? OCT as well as fundoscopy, the algorithms are together or what it is? How do you grade? Is it only fundoscopy or it is OCT together?
No, sir, ma'am, combining both will be better, but if not available, then we only fundoscopy.
So in teleophthalmology, it would be little difficult.
Please give the mic, please.
Today, the algorithms are made to train just by using the fundus photos, like I was mentioning about the diabetic macular edema. They are combined and trained to diagnose the OC from the fundus photo how much of edema is there. Similarly, that's how these photos are made, the fundus photos are used to be trained with OCT, along with the OCT, to recognize just from fundus photos whether CNVM is present and all that stuff. So it's a work in progress. Today it's still not there, but that's the way it will happen. So the whole idea is just to use your fundus photos and identify those lesions.
Yeah. Thank you, sir.
Thank you.
Yeah. Dr. Indra Rastogi, please do come.
Dr. Sandra, I would like to know that since you have been practicing in Jammu for a long time, and how AI has helped you to cross those geographical barriers and overcome, and especially in wet ARMD, what are the challenges you faced while treating those patients?
So, ma'am, in J&K, basically, because of the hilly terrain, it's very difficult for the, ophthalmologists are it is such a big state, but ophthalmologists are mainly in precisely, they are only in 100 kilometers only. So the whole of the other area is like without ophthalmologists. So with these AI tools, with the help of optometrists, and now we are training school teachers also to get photographs. So with their use, we are able to penetrate more into the population. Thank you.
Thank you so much.
Thank you, Dr. Abhishek. With this, we move to the next talk by Dr. Indra Rastogi. Sir will be telling on AI-based smartphone apps in ophthalmology.
Good morning. Well, the latest in smartphones and all that has been explained or very well given the version by Dr. Kim So. But this is basically an overview of what is available for the general ophthalmologist and what basic things or by Indian ophthalmologist we are having in teleophthalmology tele-apps. Smartphones have ignited massive change in human interaction across the world and also had an impact on our diagnosis and practice of ophthalmology. These apps provide us a wealth of knowledge and information and essentially with the tap and scroll of the screen. So that app, when we are examining patients and documenting findings. App is recommend to the patients and those help in professional educations and practice management. So there are numerous apps which are helpful to the patient and the people with low vision also, not only navigate their smartphones, but also their environment and improving their daily lives also. So this is basically the mobile-based technology is again the future of the telemedicine, outreach activities and visual acuity helping. There are so many apps and capable of detecting vision degradation even before they present to the healthcare professionals also. So by this, the patient becomes more engaged and direct interaction, and we can, low cost, we can have their compliance is increased. And these applications are capable of improving disease outcomes as well as diagnosis, and of course alleviating the vision threatening problems. So many apps, they have increased in numbers with Android and iPhones. Some apps are available in Android, some are available in iPhones, and around 300 apps are for general use, general healthcare also. So around 75% of the apps are available for free, but some are having cost. Some are, given free trials also, but they later on give the cost on that. So these are apps as per utility and operating systems. Even for amblyopia we have got, even for vision screening we have got. So low vision assistance also we have got. And of course diabetes, ARMDs, they are all innumerable apps. So more than, they have reviewers also, they are designed for non-eye care practitioners also. Eye test app, which is designed for general public, is the largest number of the reviewer rating, and it is the app which is having maximum reviewer is smart optometry app. So they need validation also. 4% apps are claimed by the developers that they have been given by some validation test. And these apps were designed by eye care professionals without developer involvement. 10 apps were endorsed by eye care professionals. But this one app which has been approved by FDA is My Vision Tracker app, is the first app which was developed. So basically, this is how the given smartphone applications in eye care. So many things is there. And another app is Peak Acuity app, which is highly validated app. It is capable of accurate and repeatable acuity measures in either set in elderly population. App is efficient tool for school screening also, and it can be used by non-ophthalmic staff also, and not in Indian population but in Chinese and Australian population given satisfactory results. It has been developed by ICH in London. Another is Ophthalmology Guide, which is a well-organized and topic-oriented e-book app, which is showing systemic details of every topic and subspecialty. Includes latest ophthalmic instruments also, and it is very convenient for the ophthalmologist also. There are specific guidelines for the use. Another app is iTube app, which is basically global ophthalmic video pool. It collects all the professional videos in ophthalmology and educational surgical videos with free access also. Breaking news are also given that. It saves time and energy when we are searching for the latest thing on the YouTube or Google. Another app is Community Eye Care app, which is free online and offline access to the peer-reviewed articles. It aims to improve standardization and enable easy access to eye care knowledge for all categories, and it is supported by NGOs like Conrad Hilton Foundation, Sightsavers, Orvis, and Seva Foundations. Free hand book app, which is basically for the diagnostic and treatment reference. It is a one-stop shop for multiple needs of ophthalmic practice, and one of the most popular app amongst eye care professionals with over 500,000 download and 25,000 active users. It includes a near vision chart, Amsler grid test, macular degenerations, and color vision testing also, and coding guides, videos, reference, everything is there into that. and it has been mentioned and endorsed. Smart Optometry Eye Test for Professional app is basically, it is available in many languages for both the phones, Android and iPhones. It is fast, easy, and results are accurate, reliable, and clinically validated. And one of the most downloaded app by healthcare professionals with more than 50 to 60,000 downloads. So various vision screening tests, including color vision, near vision, amblyopia, they're all there in Smart Optometry, this app. Another is My Vision Track app, which is just now told you. It converts Apple smartphone into a medical device itself. It tracks the progression of the vision damaging disease such as ARMD and diabetic retinopathy. And patients' data are automatically uploaded to the patient's portal. And it is validated as a remote monitoring tool at home to track treatment and detect diseases. So LI is another app which is also approved for monitoring maculopathy, but it is having a cost on it. So many the app are available in market, and especially by Indian ophthalmologists. They're like toric IOL markers by Dr. Dholaki, also iToric by Dr. Patwardhan. So these are all available and almost without cost. So another is visual intervention kit with analytics for special children, where they give visual exercise and cognitive visual functions, autism, cerebral palsy by Arvinda. And Dignify app is again by Arvinda, and but it requires smartphone with operating system, Android also, and Dignify hardware platform. It is best app for the visually impaired without using Braille, and cost is free for basically to help them in daily activities. Another is Ogalcam Medical Records app, which is by Dr. Meher Wade, and again it requires a smartphone, so patients' reports and fundus records, they can be kept on that. Language apps are there by again Dr. Akara, and so in different languages, this app gives you so many things on that. So it has got another apps are 3D Atlas, Eye Dr. JD, Eye Grader. Another is MI RedCam for fundus imaging, and so many things are there. These companies and institutes in India have changed the diagnostics and treatment by teleophthalmology. So most innovative apps for visually handicapped persons, like Samsung Goods Wife, Be My Eyes, and LV Free Vision Enhancers, Iris Vision, The Voice. So future and conclusion is concerning professional education apps such as Eye Handbook and Eye Emergency Manual apps. They are by institutions, and they are well endorsed. We need to have proper guidelines for the appropriate apps which are to be suggested. And again, just like Dr. Rajiv has said, that RSI, DI, and BSRI have come up for guidelines. So interdisciplinary collaboration in the design, development, and validation as app is required. So these apps should be low cost and should be able to guide the patients. Ophthalmologists have to be aware of these apps, and so that we can do the best for the patient. Thank you.
Thank you, sir, for the extensive information on all these apps. By the time Prasanna is getting ready, just to add that Dignify app, as you have told, for the low vision aids, because when we were working in Arvind Hospital, Dr. BG Madam, Shetty sir, and Sahitya, actually it is very, very helpful. With the help of Mindtree, they have done Arvind system, so it's very useful for LVA patients. Similarly, almost all the time-tested investigations for ophthalmology were with the help of apps, it's becoming easier. So let's see in future, it will definitely help the eye health professional even more. Thank you, sir. Thank you.
Thank you very much.
So,
Are there any regulatory bodies, and how reliable are these apps, and how do we trust these?
I think Dr. Kim
apps?
would
Kim, sir.
Are there
highlight
any
on this.
bodies who regulate this kind of?
These software as a medical device, SMD, has to be certified CDCSO. It's a central government body. Now it has been there for the last, I think, 2 years, where they've started certifying these smartware applications as a, so only those should be used technically. So they certify them.
Because many of the apps are used by patients themselves.
Yeah.
So
Today there are so many in the market, but today, I mean, for the last 2 years, now that certifying body has come in, they go through this process of safety, all that factors are taken into consideration. So any application has to go through that.
Sir, can
If you're
TOSI,
using it as a medical device.
sir, can
Thank you,
TOSI
sir.
be any help in the selecting apps?
No, we can't,
Sir,
I mean,
where-
we can,
where to work, sir?
we
Where to
can
work
take
up?
a list of those which are really certified. We can't do the certifying, or we can't,
Recommend-
I don't think we have the wherewith to evaluate these devices. I mean, these softwares.
Thank you, sir.
Thank you, sir.
With this, Prasanna, smart evaluation of teleophthalmology with augmented reality and AI. Prasanna.
Thank you, Subudhi sir and TOSI for giving me this opportunity. So next we'll move into the metaverse in teleophthalmology. So this is something that is very upcoming and very promising, not only in telemedicine but also in telesurgery. I think these are a lot of promises which I'll be sharing. So once things which was thought to be only science fiction, right? I think many of us would have seen movies like this where it was thought as a science fiction. We are working extensively on making this a science-based reality. So we started with a smartphone application, and these are the two QR codes, one for the Android and other for the iOS. And how can we really have the patient's case sheet as a hologram, or rather, because eye being a three-dimensional structure, as you can see, it really helps in teaching to a maximum extent, but now we are slowly shifting towards working on a template so that we can have EMR or the patient's case sheet itself as a three-dimensional or a four-dimensional holograms. Here you can see the left-hand side and the right-hand side videos are synchronized. On the right-hand side, you are seeing the video that is actually synced with the phone, in the smartphone that is seeing. So on day one, if there is going to be a fundus imaging or an anterior segment imaging that is done, the templates that we have made, you get the holograms instantaneously. So the fundus examination or the anterior segment examination that you can see here can be done the way it can actually be done in the way we are seeing a patient, but the doctor and the patient may not be together at the same place. So we are trying to incorporate real fundus images. You can have any machine, Optos or EDON or CenterView eye care. So up to how many degrees that you are going to have the fundus imaging, that many degrees you can actually get it in the holograms. Similarly goes for gonioscopy as well. We have used photoreal visual reconstruction imaging to make the angle structures as realistic as possible, so that in the advent of angle surgeries and mixed surgeries coming up. So that also makes a huge lot of difference in selecting a patient whether we want to go for mix or we can go for a trabeculectomy surgery. Again, this is another patient's data. This is a recording from a smartphone. You can see that again, as I was speaking on angle, right? Whether we need to do a YAG PI or a YAG or a SLT or an MLT for that matter. And not only that, the fundus, you can see that this is a normal fundus. This is an NTG patient where there is a splinter hemorrhage. And the autofluorescence, the infrared, the filters can always be taken. The more imaging that we do for the patient, the more evaluation that we can actually do. This is again another patient's RNFL defect. It comes as a case sheet. So you can see that just like that on the left here, you can see the marker here. So the patient's data will be here, and you can see, you can choose different patient's data. As soon as it's being fed, you get the three-dimensional examination of a RNFL defect. And if there is a compliance issue, we can go ahead and do a trabeculectomy or a mix or whatever that the patient needs. So the data representation is what I'm emphasizing on, and we have validated it and published it in the European Journal of Ophthalmology, and this is the validation data of our study, which you can see here. And also we did do a commentary about this on how smart evolution of teleophthalmology can be taken forward, and it is published in the Indian Journal of Ophthalmology 2022 issue. And this is again another thing, we wanted to push ourselves more. Can we bring something called subtractive learning? Because ophthalmology is something which is more subtractive, right? We wanted to see structures that we wanted to choose. So on the left hand side, the augmented reality that we are working on, so we started using subtractive learning. That means you choose which structures you want to subtract. The more imaging that the patient has, you can see the buttons on the left here. This is helpful for even neuro-ophthalmology as well. The brain stem, the brain, you can remove structures by choosing the buttons, and you can examine the patient as a whole. And similarly on the right, you can see we have worked extensively on the extraocular muscles. If there are going to be more imaging that we are going to do, the more we can reconstruct the patient's anatomy and the more data can be extrapolated from the patient. And on the right hand side again you can see a simple eyeball model is also opened up. So there are n number of possibilities and n number of models that we can have for an EMR or for an examination for that matter. Again, e-counseling and simple simulators. A paramedical person that we send on the field for a simulative learning. Look onto this left side video here. So this is a smartphone depiction. So by moving your phone forward, you can actually train them for a direct ophthalmoscope. So I'm just going back in this video. So I'm just again going forward. You can see by moving the phone forward, you can actually train them spatial orientation. So these are all very helpful for training our paramedicals, how you need to orient yourself. Your fundus can be used as a direct ophthalmoscope. So you train them as a hand-eye coordination, how you need to enter the pupil and visualize the fundus. So then when you give them a pocket fundoscope or even a direct ophthalmoscope for that matter, they really know how to go about it because they have been trained in space. Otherwise we'll have to take a lot of teaching classes to them, how you need to go about it, and which are very cumbersome. So we are trying to accelerate learning so that these are all in smartphone. Everybody has a smartphone today. So can we do something with augmented reality, because every phone has this LiDAR technology and we are trying to extrapolate it and use it to our advantage, how we can serve the rural community better. And now we are pushing ourselves more to telesurgery. So I got this idea from one of my mixed surgeries that I was doing. Again, these are the models that we already made. This is something that we push from 3 dimension to 4 dimension, where all the dimensions of the same that you saw on the smartphone can also be seen. Tomorrow you will have the patient's data and you will wear a headset, you can open it up, you can pull the OCT out and then see the patient as a detail. Like a diabetic patient walking in, fundus and OCT is done. So this is already possible, already done actually. This is no more a science fiction now. So the patient's database enters under 60 seconds, under no chart time. The OCTs also can be extrapolated out from the patient. You can see that the OCT slices can be extrapolated. You can see the patient for what they are, and we have also evaluated it and published it. So I think COVID really served a good push for me, because that is when I had more time to reassess and think about these innovations. Right, I was doing one MIGS surgery. I did the stent and it was superficially placed. No financial disclosure, but these are heart in the mouth movements because stents are very costly. So I had to reassess myself, place the second stent first, then I tried to retrieve the stent that got dropped. So but when I was coming out, again you can see I was about to lose it in the phaco wound. So I had to reassess and then take it, then go ahead and then implant it. This is a very novel procedure which came to India in 2021. Not many surgical videos were there for teaching. So I went back to my drawing board, and in the headsets that we were using for diagnostics, so we went ahead and created a simulator. You can see that with this headset that we have innovated, this is in metaverse. The hands that he is moving, you can see it is coded in the metaverse, and it's a portable simulator and a very cost-effective one. Now, it is that you can take the stent, practice it 30 times, 40 times, or how many times that you want to, because these mixed surgeries, angle surgeries cannot be practiced in a goat's eye or in a cadaveric eye because the angles are collapsed and not many models are also available. So every time the stent is placed well, a green light comes and its 3-dimensional spatial orientation is clearly developed. The cognitive skills are developed and you can go ahead and place the stent well. And we have also patented this innovation of ours. So, and also we ended publishing it as well, an immersive photoreal 3-dimensional augmented reality for mixed training. So these are all real and happening, and I think we are all going to work together along with the missions, and we are going to utilize human intelligence along with the mission, and this is another facet of us which will help the community, where humans can train the mission to pick up subtle findings, not only diagnosis, how we can predict what is an RNFL defect. So if you feed a fundus image, not only the diagnosis you can see in this image, even an RNFL defect can be predicted. So we can break the black box dilemma. We are trying to create explainable AR modules, explainable AI modules, so that black box dilemma does not play a role, and we have an explainable AI so that we diagnose, not only we diagnose, you can see along with diagnosis, the intricate findings are also arrived. See, maybe we need to spend 1 hour for an image training it, but that all comes back in a way that not only you get the diagnosis, now the machine gives where is an art exudate, where is a cottonwool spot, where is a neovascularization. So this helps us in developing an explainable AI, and that is the way forward, is what papers are coming out, and we are also coming out with our own data. And holistic AI, you can see that not only fundus, but you'll have to merge the OCT as well. In OCT also, if you're going to feed the left-hand image, you will get the diagnosis and each single intricate findings. What is it? The way it is. A non-exudative ARMD, again a OCT of the same. So I think it's a very promising time, and again an exudative ARMD. You can see how much the machine gives you at the end, not only the diagnosis but also each finding. I think these are modules of us that we have innovated. In less than 60 seconds, most of it is in the alpha testing, and we are soon trying to launch it, and we are also evaluating it, validating it, and also publishing it. So we are going to work together between the doctor and the mission. We're never going to compete against each other. It's all for the better humanity. And I have my own startup called the Mahatma Center of Moving Images. You can catch me at www.mcma.in. And this is my team of ophthalmologists, optometrists, and technicians. And all these that I presented, we have created this. Thank you once again, Subudhi sir, for giving me this opportunity to talk on all my 4 innovations. Thank you once again.
Next up, please.
Thank you. Excellent talk, Prasanna. So, very good. So, our next speaker is Dr. Sabyasachi Patnaik, teleophthalmology setup. Prasanna? Yes, sir, please. Rajguru sir.
Sir, the financials, am I right, sir? So the apps that we have launched, the applications are actually now available to download free of cost. Even the ones that we use, the headsets, the application is now ready, sir. Every institute will be having their own headsets. It will be a Geo headset, it may be an Oculus, or it may be a HoloLens. So the application is, we have made the application and we have launched it. But now it is for each individual to download it and utilize it and see for whatever speciality that they are. So since I'm a glaucoma person, I started with making a mixed simulator and more of glaucoma related artificial intelligence. And my associate takes care of retina. So we are more into glaucoma and retina. I think it's now the individuals, they have to use it, give their feedback, and we can keep upgrading the models. Yes, sir.
So, respected teachers and dear friends, now all of us are convinced that teleophthalmology is going to be the way to provide universal eye care services to the people of this country. So I don't have any financial disclosure. What I am going to do is to tell about how to start a teleophthalmology setup for your practice. Then, thanks to COVID, the teleophthalmology guidelines have been made by the Government of India. So we have to be conversant with the provisions of the telemedicine guidelines that has been published by the Government of India, and there is a clause that everybody practicing telemedicine has to be trained within 3 years. Now, ophthalmology, as you know, is an image-based specialty, so we can have 2 types of teleconsultation, either real-time with video-based or audio-based interaction with the patients, or store and forward model, where we can take images, as has been discussing. Also, there can be a combined model. You can ask the patient to take his photograph or fundus photograph and send it to you. Then you can have a video consultation to direct interaction with the patients. So you have to first decide the purpose of setting up a teleophthalmology program in our practice. It can be tele-OPD or home OPD service. You can have e-vision center, where ophthalmic assistant or optometrist will be there in the vision center. They will interact with the patient directly, and you can remotely communicate with the patient, diagnose, and also prescribe medicines. Then you can have mobile teleophthalmology camp also, like this diabetic retinopathy camp or glaucoma screening camp, or even comprehensive eye screening camp with AI-based apps that has been discussed right now. And we can also get second opinion by doing online consultation with the experts. Now, these are the conditions which can very well be diagnosed in case of home OPD services. So the patient didn't have to come to our clinic to show his conditions, and we can trace those patients, and those really need physical examination should come to the hospital. So setting up a ophthalmology program in your practice, you have to decide how you want to use the telemedicine. You have to have a plan. Ask yourself, what do you want to accomplish with telemedicine? Start with just few services. Begin by limiting it to simple services like follow-up patients or minor. That we are also now it is doing when the patients are asking us for something, we are asking them to send us their pictures of the eye through WhatsApp, and also we are trying to diagnose and providing the consultation. So make sure patients are aware that you are offering telemedicine. Now for setting up a teleophthalmology program, we have to have proper equipments. So dual screen monitor is advised when you want to have a video-based direct or real-time telescreening. Internet usually more than 2 Mbps speed. Then choose proper telemedicine software and apps. So you need to have a software where you can have a video-based consultation or image rating. We, through TOSI, are working out with different manufacturers, software companies, and also these manufacturers of equipments to provide a software that can be used by the ophthalmologist. That we are still trying to get it. Now you have to provide a proper space, a quiet room with adequate lighting, and also have to do certain real-time runs before you actually start this in examining patients. So just like your physical examination in a real mode, you have to present yourself properly in teleconsultation also, dress up properly, be punctual for tele-appointments, then develop good manners when dealing with the patients, and it is required, as per the telemedicine guideline, the identity of the patient and the identity of the doctor has to be ascertained first, and the consent has to be taken in real consultation has to be also followed for teleconsultation also. So we have to prepare the patient for this also, should be informed beforehand. There has to be a proper connectivity with the patient. We have to remove the apprehension in the mind of the patient, because this increases the response and leads to patient satisfaction. E-Sanjeevani portal also is provided by Government of India to have teleconsultation services in which there is both tele-OPD and app-based tele-examination, as has been discussed right now, are there and developing, so we can have home assessment of certain things that can be done with mobile apps and also can be communicated. There are advanced features like AI incorporated equipments, drone slit lamp which can be remotely operated by ophthalmologist, home OCT and other things are coming up, handheld perimeter, preferential hyperacuity perimetry also. These are all being tried and ultimately will be incorporated within few years. So we have formed Ophthalmology Society of India to for formulation of guidelines. Online training is being provided through Eco India to different paramedical staffs. Then we are going to develop teleophthalmology models as per the need of the ophthalmologist, procurement of equipment, software, and video platform for real-time consultations, and also to handle legal issues. So to conclude, teleophthalmology can be an effective and feasible model for providing universal eye care, and we have to now develop standardized teleophthalmology solutions and user-friendly SOPs. So public awareness and orientation is a must. So let us all get started to this changing digital world of eye care. Thank you all. Thank you very much. Our president, Dr. Natarajan, is held up in some other session. So for his talk, I think I will ask Dr. Amol to speak on that topic, about 5 minutes. And any questions for Dr. Patnaik? I think it's a really wonderful setup he has already existing. And I think TOSI will help you all for this software and everything shortly. Next, Amol.
As compared to 2010 in 2019, and also the it's a relative reduction of visual impairment from 2010 to 2019. So this is what we are doing we are believe in a community participation is the best way to deal with the blindness. So we have Kamala Sundaram Foundation, which basically it's a community-based organization which deals with the comprehensive eye care. So we conducted several camps in the Mumbai, like Matunga and Chembur, Dharavi. So basically what we do, we detect the basic ophthalmic problem the patient have. And then according to that, we categorize it and then we deal with it. who the patient who need a refractive error, for refractive error, we prescribe spectacles, and those patients having diabetic retinopathy, we screen them and then we give a proper treatment. So this is a logo of our foundation. So this is all about our foundation. So it is basically, this foundation was an idea of Dr. Natarajan sir with the help of Dr. APJ Abdul Kalam. And this foundation runs outreach program in rural and urban slums, tribal areas, strive to provide quality eye care for underprivileged patients. It has a numerous project focused on creating awareness of screening and providing comprehensive eye care services to avoid the blindness. So this organization conducted several camps till date. So what is the vision and what is the mission of our organization? So to provide the quality eye care, all those who need it, and to render the charitable services through the system built on the social participation. Because in India like country, the community participation is the best way to deal with this blindness. So we have, we conducted different projects and activity like CREAM project. Then for diabetic retinopathy, we conducted AGDRU SS project, Pearl project, Stop Blindness project. So these are different projects we conducted. So they are our trustees. And they are our accomplishment. We screened 10 million lives, awareness drive, slum dwellers, different parts of Mumbai, who is very underprivileged and who are not able to access the services. So also children's also is screened for eye diseases. And we also collaborated with the World Diabetes Federation to have a diabetic retinopathy project. So these are our some few publications in JAMA Ophthalmology. And we also collaborated with the biopharmaceutical to have a lab, research lab. We have a research lab which conduct the molecular biology lab with Oxford nanopore sequencer, PCR machine, high-speed refrigerator centrifuge, the microcentrifuge, and DNA quantification. So we deal with all these programs. So the research activity we are conducting to prevent blindness. Our research objectives are to understand the disease mechanisms, to discover the therapeutics and translate the research to better. Yeah. So these are the different Mumbai ophthalmology reading centers. And this is our different international collaborations we have. And this is the outreach. We are providing vision screening glasses and detecting the different disorders through our camps like cataract, retinal disorder, glaucoma, and we also detecting a squint pediatric cataract patient who need a treatment. For the other camp activities, different. And just I wanted to mention one thing, we are using Remedio camera. For Remedio camera, we are using for diabetic retinopathy screening, which is very, I feel, everyone was speaking about AI in ophthalmology. So what I feel, what we are using through our program, that is the Remedio camera in DR screening. So that is what I feel very important. Thank you so much.
Request Dr. Jain to give the concluding remark before we take the photograph. So be here for another 2 minutes, we'll take the photograph. Dr. Jain to give the concluding remarks.
Yeah, so now that after realizing all from Kim Search to everyone, the era is the mobile. Android mobile system is the ultimate for teleophthalmology, basically as we are from a community services, that for community world, and as maximum number of our population are from that a rural background where there is no such infrastructure is available. So I have some documentation, but due to the lack of the time, is not possible for me to show those slides. I want to cut short all everything very in hurry. So basically I am practicing in oculoplasty and neuroophthalmology. In oculoplasty and neuroophthalmology, it can be very easily. Sometimes in the village workers, they are telling it is a facial nerve palsy, that epiphora, but ultimately is a facial nerve palsy or logophthalmos. There may be I teach lots of my students. They are calling, sir, what to do? There's a dog bite. Then what to do, we can go for one by one. So as you are and all are in hurry, so I conclude it and just I appreciate the Prasanna's talk basically, that is the ultimate one. And this is a very practical tips, and we can just conclude. I think our next session is going on, it is waiting, so please.
Okay, thank you very much. Next session, please.